We're also planning on switching things a bit from the last webinar. If you remember, in the last webinar, we began by directing you to the toolkit where you can find the resources about where you can find resources that are necessary or relevant to the topic. Sorry, I think there's some noise somewhere in the background. Please mute yourselves. Thank you. Okay, so like I said, we want to switch things a bit from the last webinar where we started off by giving you information that is related to the toolkit. And today we will give you a quick overview on the topic of discussion, and then we will move on to our experts and have them share their knowledge, experience, and expertise. And then towards the end, after the Q&A session, as we wrap up, we will give you an orientation and point you to the toolkit resources. So in today's session, please notice that because we are talking about resource navigation and we are talking about staffing for navigators, there may be some topics that will sound similar to what you've had in the previous session, but use it as an opportunity to gain more clarity and to build a deeper understanding or to enrich your understanding. At the same time, if you attended the last session that we had for clinical navigation, you might find that some of the toolkit references we are making are the same or similar in one way or another, as well as the advice that we give. Use this again as an opportunity for continued learning, and perhaps it will even clarify some of the questions that you have continued to have possibly after the previous session on clinical navigator role. And of course, we do hope that from today's session, you'll be able to figure out how to continue building your staffing aspect of your patient navigation program design. So welcome all. And to remind you again, as we come to the end, we will give you some quick reminders and also do our end of session survey. We like to hear your feedback because we use that feedback to build in our improvements as well as enrich your experience. So remember to take just that 1-2 minutes to give us your feedback at the end of the session. So over to you, Christy.
Hello, everyone. I'm Christy McComb with the American Cancer Society. Really excited to be with you all here today. So before we jump in, we want to just go over the feedback from the last session. Of course, of those who participated, you really liked hearing from our partners at Kenyatta National Hospital and Uganda Cancer Institute. So again, we try to bring these experts to you on these webinars, and you'll hear from more today and in the future. Some folks said, what didn't go well? One of their questions didn't get answered. This was really helpful for us because actually we thought we'd answered the question. So hearing that we didn't might suggest that maybe there's a language challenge, there's a technology challenge. So again, if you don't feel that your question got answered, let us know. You can also, in the community, as you know, there's a place at any time you can ask a question.
Recording in progress.
Are open to giving you that feedback on your question. Also, we got some more suggestions for future webinars. Again, we're talking about resource navigation today, which is one of the bullets here, lay navigation. We're going to also bring some actual navigators to talk to you in the future from some of our partners. Someone made a comment about needs assessment. We did do a session on that a couple of months ago. So I want to also point out that we do have recordings for these different sessions. You can go back and watch them. If you feel that, yes, Christy, I watched that and I still have questions, then I highly suggest you reach out to us and we can really try to understand what your specific questions are and help you. We're already doing about 2 sessions a month. So we're always being mindful of your time and how many sessions we can do. So just to say, we may not hit everything, but definitely reach out to us. We're here to help. And again, we hope that we get participation from you all today. Looks like we have about 40 people on the call. We've been averaging 6 to 10 responses. We'd like to get those numbers up. So that's my request to you in advance. All right, next slide, please. Quick poll. We have 2 questions today. And again, this just helps us understand who is on the phone call. Can we switch the slide too, please? So the two questions we're trying to understand is what you currently have in place for resource navigation and or what you're planning to do. And also if you have a program or plan to, what types of navigators will you employ? So the first question, what's your plan? What is your current plan? What's your current program or what's your plan? And then what types of navigators do you currently employ or plan to employ? Sorry, I messed that up. The poll should be up. Please respond. We'll give you a minute or two to answer this question. And then let's just see what is the makeup of our participants today? So Jessica, you can let us know when you're ready to share the results. Jessica, are we getting answers?
Yeah.
Does everyone see the poll on their screen? Is everything good?
Can everybody see the poll?
You were able to answer it? Yeah, I see answers coming in.
Okay.
We've got 13 people out of 38 responding. I'm going to give another 10 to 15 seconds. Please respond to the two questions. First one, which of the following best describes your current program or your plans? And then which types of navigators do you currently employ or plan to employ? So that is, are you looking to just have one type of navigator or are you looking to add different types of navigators into your program? And if you don't know, that is totally fine.
Okay, so we have 14 out of 34 respondents, and I'll be closing in 5 seconds.
You can click on the poll button at the bottom if you're not seeing it.
Okay, so I've just ended the poll and sharing results. As you can see, 33% currently employ resource navigators. About 40% of you are planning to hire navigators. So this is good because then from our discussion today, you get to hear some hands-on experience about how people have gone about it. And about 27% of you do not plan to and do not employ. Are quite okay and in order because the needs might evolve as you move on. And perhaps that may be the reason why you're here amidst other reasons. And then of course, we have which types you do plan to engage. And we can see 47% of you, clinical navigators, resource navigators, again at 47%, physical navigators at 47%. Those that do not know yet, today should also shed some light as to what's possible for you in the realm of the discussions that we are having.
So it seems like there's a lot of interest in the different types of navigation. So that's good to hear, and we look forward to continuing to talk with you about what you're planning to do in the future. Okay, thank you. So next slide, please. So introduction to resource navigation. Today we're going to start off with a brief introduction to resource navigation, how it helps to address patients' needs and key barriers to care, many of which are actually not clinical in nature. As noted earlier, we're going to invite our experts to talk about their experiences serving in the role of resource navigators, recruiting and supervising resource navigators, and their advice to help you meet your resource navigation staffing needs. We're also going to look at this importance of delineating roles. We talked about that 3 weeks ago, both within your team and within healthcare. Alice, can you help me with muting, please? We're getting a lot of interruption. Thank you. Okay, And finally, we're going to talk about at the end about the toolkit activities that will support you in this. So next slide, please. What is resource navigation? Next slide, please. Yep, thank you. Resource navigation is a type of patient navigation that addresses logistical, financial, and other resource-related barriers that impede timely and appropriate diagnosis and treatment. So if you look at our graphic here, last time we talked about clinical, we're talking about resource navigation. In 2 weeks, we'll talk about physical navigation. But we really see when it's possible to bring all of these to fruition, they really support these various needs of patients. And when we look at resource navigation, this is actually historically where the American Cancer Society has done its navigation work, is in this resource navigation space. You'll hear a bit more about that today from our guest speaker. Okay, thank you. So what's in a name? Have you heard these other terms before? Lay navigator, non-clinically licensed navigator, or patient navigator? Maybe you have, maybe you haven't. In the United States, you'd be surprised how many different ways we talk about the person who performs this role of resource navigation. So sometimes, I'll be honest, it can create some confusion. When we set out to build the toolkit, we actually made an active decision to call resource navigation and resource navigator to really focus on the common barriers that resource navigators are going to address and the functions that they perform. And that's the same with clinical navigation and physical navigation, thinking about those types of barriers. So you'll hear today different ways that this gets defined, but just to say, we want you to be clear what we're talking about. And then of course, when you figure this out in your setting, you may have some cultural or linguistic reasons why you choose a different name. The main thing is whatever you choose is that the people who are doing the work understand the terminology, the people that you're serving understand the terminology, and that roles are clear, as we'll talk about later. Okay, next slide. All right, so what do resource navigators do? These types of navigators generally assist patients in accessing health facility or community-based resources such as accommodation, transportation, childcare, legal services, food support, support groups, financial support. And all of that is to overcome these logistical challenges and logistical barriers to care on one's treatment journey. One of the things that is really important in our experience with navigation, with resource navigation, is that these type of navigators cultivate partnerships and really develop that in-depth understanding of community resources that will practically help patients to overcome these logistical and financial barriers. And I just want to point out, we have in section 1, this handout that gets into these different types of navigation and defines resource navigation for you. So that's 1G1 handout. And again, what are these main roles and responsibilities? Resource navigators are providing psychosocial support and connecting patients to psychosocial support services and resources. They're fostering and maintaining these relationships with service providers, again, perhaps inside the facility, but often outside, who can help patients link to transportation, housing, other needed services. And they take an active role in referring patients to other providers and services within and outside of the health facility. Again, I want to acknowledge this handout in section 4B3 gets into common navigator responsibilities. You may, again, decide within your facility, you're going to do a subset of these. It really depends, again, on the barriers that you need to address, but we're going to hear a lot more from our experts today. Okay, and this is just a call out to the cancer organizations that have joined us today. Really, resource navigation and the specific efforts of resource navigators often straddle the healthcare facility setting and the wider community. And often resource navigation services in a health facility may be provided by an outside organization. Again, that's our experience in the United States as the American Cancer Society. Cancer organizations and the navigators they provide can create those linkages and connections to the wider community where patients come from, where they live, and where these supportive non-clinical services may be offered. They can also provide specific referral services for navigators to connect patients to. So again, in the United States, as the American Cancer Society, we both had our resource navigators as well as transportation services and accommodation services that the American Cancer Society provides. So we were both linking patients to other services as well as our own. And finally, what you may bring to the table is this voice of patients and caregivers, as your navigators may come with that background and now want to give back to other patients who are facing a similar situation. So this is a place where your organization can shine. All right, with that, I'd like to invite our two experts today. I call them the ladies who wear many hats in patient navigation. You have actually met them before. Heather Ciccarelli is our current at the ACS Director of our Patient Navigation Initiative. She's a former Senior Director of Patient Navigation, as well as a former patient navigator, resource navigator. Really excited to have her here today. And our second speaker is Nancy Peña, who is the founder of Navegación de Pacientes Internacional. Hopefully I said that okay. And she is a current patient navigator for gynecologic oncology clinics at Dana-Farber Cancer Institute and Brigham and Women's Hospital. So we're going to open it up. Each of them is going to give about a 1 to 2 minute introduction to where they work, how they work. And then I'm going to ask them a series of questions. And then we're going to open up to the wider group for your questions. So as you maybe come with your questions, or they come up as you're hearing the discussion, please put them in the chat and you'll have a chance to ask those later. So we're going to start with Heather. Heather, can I invite you to come off mute and introduce yourself, please?
Sure. Good morning. I'm Heather Ciccarelli. Happy to be here and talk about my experiences doing resource navigation myself, and also supervising resource navigators. And certainly at this point with our patient navigation experience, I've had the opportunity to learn a lot about lots of different programs across the country as well.
Did you want to, Heather, show your 2 slides yet, or?
I can, however we're doing it works.
Okay, so maybe, well, let's let Nancy introduce herself and then we'll come back to you and have you a little bit about ACS. So Nancy, please.
Yes, good morning, everybody. Nancy Peña here. I am the director and founder of Navegación de Pacientes Internacional. Under this organization, we train navigators in Latin America in Spanish. We also are able to train in English in different other countries. I actually work as a lead patient navigator at Dana-Farber Cancer Institute and Brigham and Women's Hospital. And I have been working with Dana-Farber for the last 16 years. And also being able to develop different patient navigators, protocols, and projects in inside and outside of the United States. Thank you.
Thank you. Okay, let's advance to the slide. There's 2 slides after Heather's name. And then Heather, maybe you can just talk a bit about how ACS has approached resource navigation.
Sure. So ACS has been in the patient navigation, resource navigation space, I think probably for about 20 years, and it has certainly evolved. So at the very beginning of the program, our navigators were friendly faces that patients could go and find, and they would share information about programs that the American Cancer Society offered. So information about your diagnosis or help with rides or finding other people who had similar diagnoses to you. And later, really became a very robust partnership within hospitals. So navigators, resource navigators were placed in hospital settings and worked with the clinical navigators and the social workers to help meet some of the gaps or barriers or things that were preventing people from coming to care. So it definitely got much more involved as time went on. And I would certainly attribute that to the trust that hospital partners had in the American Cancer Society as the navigators helped get more patients to care, and also just the increasing need as we got more evidence that there were people who, without assistance or support, would not complete their cancer care. If you want to go to the next slide. I think one of the most important things is finding the right person. And I think that there are a lot of things that you can teach people about cancer or about medical systems. But for me, in hiring, it really very often came down to the personality and finding the person with the right skill set. And the best navigators in my experience were the ones that were problem solvers, that they could sort of see connections between a solution and, you know, a challenge, that they could build bridges and make relationships, that they could prioritize and deliver on what they said. They were good communicators, people who aren't afraid to ask questions. So I think one of the things I learned early was that if I called and said, I'm looking for somebody who needs assistance with food, the person on the other end might say, we don't do that. But I would always say, can you tell me who might be able to do that? Or can you think of anyone I can talk to? Or who do you know that can help with this? And then sort of keep going. So we certainly have had experience as well using people who had personal experience with cancer. I think the important part, no matter who you hire, is to make sure somebody has very good boundaries, that they know what their job is and what their job isn't, right? So there has to be, you know, it's one thing to refer somebody to a food pantry or help them find some assistance getting food. That's the person you want. You don't want the person who's going to drive to their house and drop off groceries, because that's, you know, in here it's a little bit of a boundary issue. So you want to make sure that you find somebody who understands that they can make a big difference as long as they understand the confines of their job. So I think we're going to talk a little bit later about, you know, the difference between being an effective navigator and addressing the problems that present themselves within the hospital that are something that a resource can address, and trying to be responsible for, you know, fixing the entire system or society, which leads to burnout very quickly. That's all I'll say for now. We'll let Nancy talk a little bit about her experiences, and then we'll answer some questions.
Sounds good. Thank you. Nancy.
Yes, thank you. So I don't know if we can go to the next slide, one of my slides, please. Okay, thank you. Yes, so I was asked to talk about, you know, the navigation role here in the United States and Dana-Farber, and also in Latin America. So I'm going to start sharing with you what are the criteria for hiring a navigator at Dana-Farber Cancer Institute. So basically, as we can see here, we are asking for a high school diploma or GED, also a bachelor degree is preferred. Also, we are looking for candidates that have more than one language than English. So it could be Spanish, or could be Portuguese, and other languages. And this is because, of course, you know, we are serving multidisciplinary communities. We are having people from all over the world coming to Dana-Farber and Brigham and Women's. And also we are asking for some experience, especially if they are working with patients in the past or doing some outreach experience in the community. And we prefer to have candidates who have a certification in patient navigation or some kind of background as a community health worker. And definitely, as Heather was mentioning, a person who understands the culture and also knows about where the resources are. Because most of the time, our navigators, including myself, we are going to help in a daily basis with different resources for patients. And the job description on the right, you can see that we are asking for more tasks to be delivered. But most of the time we are looking for a candidate that can bridge a great communication between staff members and patients, and also resources outside of the community. Most of the time, we are also looking for a navigator who is willing to translate the information that the patient has to the staff member and vice versa. As we know, sometimes patients are very worried about the diagnosis, and sometimes they forgot about asking questions. So we definitely want a navigator who can address that kind of issues and encourage and motivate the patients to ask specific questions when they are having an appointment with the doctor, so they can optimize their time. Because of course, you know, sometimes we have doctors, and this is universal, right? And the doctors can see a patient perhaps for 15 minutes, 30 minutes, and perhaps if this is the first appointment, could be like a 45 minutes, an hour. But as we know, patients are so blocked and worry about what is next, and they forget to ask those questions. So we really want to have a navigator who can help patients to build that. On the other hand, right now in Dana-Farber, we are our program is growing. So right now we have 4 navigators. We have one for GYN. This is myself. We have for breast and gastroenterology, and we are hiring one new navigator for thoracic. We also have other navigators at Brigham and Women's. We have one for the neurologist in emergency room. And also we have resource specialists and social workers. So sometimes our navigators are overlapped with some task, specifically with resource specialists. Resource specialist is a person who provides resources to the patients, but they are more focused on just in the resources. They are not working, you know, hand to hand or face to face with the patient. And when we have those cases, we collaborate with the resource specialist at Dana-Farber. The same happened with social worker. Our social worker model in Dana-Farber is to provide more like a consultation for anxiety, stress, depression, etc. And we have more resources, but I'm just going to mention those 3 because I don't want you to be confused. So as we can see, we have so many levels of different roles in Dana-Farber, but still, even though we overlap, we know when to step out and when the resource specialist can continue working with the patient. Perhaps the resource specialist is going to work with the short housing accommodation, meaning that they are going to provide a hotel room for the patients. But at the same time, the navigator will still keep working with the patient in terms of educating the patient about you know, appointments, educating the patient about who is in the team, and also support the patient when coming for appointments. And again, social workers will support patients to address mental health issues and other you know, situations like anxiety and depression. The next slide, please. So now I'm gonna share some information about Navegación de Pacientes Internacional. This is a nonprofit organization that we found 3 years ago. Maritza Chicas is one of my colleagues. She is actually here in the room chat. And we found Navegación de Pacientes Internacional, or NPI, to train navigators in Latin America. And we, you know, as a Guatemalan person and as a lead navigator, I understood that navigation can be applied in different settings. But also I noticed that we don't have a lot of trainings out there and certification in different languages. So we become with the idea to organize NPI, and recently we have been training more than 60 navigators in Latin America. This year, we certify navigators from Guatemala, El Salvador, Colombia, Peru, and Argentina. And our next training is coming right now in October. We are able to train people in English also if needed. Our training is different than the trainings are in the United States. In the United States, I can tell you that because I have certifications from different organizations. Right here, sometimes you can have a certification attending a training for 2 or 3 days. Also, you can have a certification if you are a member of the Academy of Oncology Nurses and Navigators. You have to pass a test and have some criteria. With us, it's a little bit different, because we are accommodating the needs and different cultures, right, than we have in Latin America. So we provide a training of 2 days of theory and 6 months of practice. In those 6 months, navigators has to navigate at a minimum of 1 to 3 patients, maximum 5. For 6 months, they have to get back to us every 2 months to review the cases, the data. And the most important is to build a network between all those navigators in Latin America, since we are having a lot of immigration situations right now. As we know, people are coming from Venezuela, Colombia to Mexico, Guatemala, going to the United States. So we had to build that kind of navigation to support and understand the needs of patients traveling. So in MPI, we are seeing then a lot of navigators in Guatemala specifically, because we are working in Guatemala, working in other countries, and El Salvador also. We see then the majority of navigators are volunteers. And those volunteers sometimes are survivors from, breast, cervical cancer, etc. And they want to go back and give something to the community, something back to the community. Also, we learned that some organizations, nonprofit and private organizations in Guatemala, they already have navigators, nurses, and social workers. And right now, San Juan de Dios Hospital, Dr. Patricia Chacon is here with us today. They are implementing navigation in the major public hospital in Guatemala. And they are still looking to see what kind of model they will have in terms of navigation. But Guatemala already have volunteers, navigators, who are supporting more than 200 patients in the last 2 years. El Salvador are doing the same, and they are having our training. And why it's important to have a training, especially for volunteers? As Heather mentioned, we had to set up boundaries, right? We understand that in Latin America, sometimes we have a different culture, meaning that if the patient needs something, perhaps the volunteer will be going to their house and provide some food, versus United States. And we don't do that because it's, we have some kind of liability. But after we have the training with the volunteers in Latin America, they are learning that to set up those boundaries, right? And also providing resources and not to get so much involved personally in the case, because that's what happened before we came to train these people. They were saying, we built out a strong relationship and now we become like a friend. And I understand that, because as a Latinos, we are very warm community, very welcome, and we want to support them as much as we can. So the criteria we learn about navigators in Latin America is that they have to be bilingual, especially in Guatemala. It's preferred if they speak a different languages. Like we have 22 Mayan languages in Guatemala. So it will be the best if we have a navigator who speaks Spanish and at least one language of the Mayan culture. Also, certification is new for Latin America, but most of them are having the certification and training from MPI. And the curriculum we use is from the George Washington Cancer Center. Also, the navigators in Latin America for the private sector, we understand, and they have nurses and sometimes medical assistants helping them. So I'm gonna stop here and back to Christy.
All right, thank you, Nancy. So a couple of things that I heard, Heather, you talked about this making those connections and digging deeper, right? And what I heard was, this is an ongoing task of a navigator to keep finding what's out there. Is that true?
Yes, and it takes a long time to develop resources. And, certainly here in the United States, resources sometimes change. So if there's a crisis, there may be more resources. If there's, some economic problems, there may be less resources. So not only does it take time to make all those connections and find, who might be able to loan a cane or a walker or a toilet seat extender in a certain community. Also, there are organizations that may have dollars that they give to people with certain diagnoses or live in certain neighborhoods. And when the money runs out, there isn't any more until they raise some more. So it takes a long time to build those relationships, to find those people, and you have to build that relationship. So, if I go to an organization and I say, I'm working with a woman, she, has cancer, she can't work, she's having trouble heating her house. Do you know of anybody who might help me pay for some fuel so that her house is warm? Once I get that resource and I'm able to help that person, I want to go back to that organization and say, thank you so much. It made such a big difference in this woman's life. She was able to, whatever it is, so that everyone understands why what they do is important. And then, right, when you go back next time and ask, or they're fundraising or trying to get some more connections, they can, help people understand why the work that they're doing is important and why it makes a difference. So not only do you have to find all those resources, which, sometimes I remember a time that I was looking for a wig for a woman, and there was somebody, I think I found somebody whose, mother had run a salon, who had wigs in her garage because she retired. I mean, it was just like this incredible connection of finding someone who knew someone who knew someone, right? And then we put it on the list, and then anytime we needed someone, next time we knew who to ask. So it's finding the resources, it's nurturing those relationships, and it's also about sharing with the medical center. There was a patient, they were having trouble with heating oil. I, through my work with the American Cancer Society, was able to make this connection, and this is how I helped this patient. And then the next time the provider or somebody at the medical center hears that somebody's having that same challenge, they'll think, oh, they need to talk to the patient navigator, the resource navigator, for some assistance.
Mm-hmm. And can you both talk about, we talked generally about the common barriers that resource navigators address, but in your experience, what have been the top barriers that patients are facing? And have you had situations where there's these really important barriers, but you haven't necessarily had the ability to connect them to resources? I'm just curious how much it's similar or different. And Nancy, maybe you can think about the different navigators you work with in Latin America are really, what are the most common barriers and challenges that you've seen?
Yes, thank you, Christy. Well, in Latin America, I can tell you the major barrier is financial barrier. And also language, especially in Guatemala, when we have 70% of our community is indigenous in Guatemala, the population, and most of the time when they are traveling to the city seeking help, language is the major barrier, and financial. In the United States, it's interesting because in the United States, I can tell you that sometimes one of the major barriers here is also the language, especially for immigrant communities, but for Americans could be family support, right? We can see that sometimes we have families or patients, they don't have any financial issues, but they do have family support barriers. Then they don't have perhaps family at that moment, or they don't want to bother families, or friends, asking them to help them and drive them to the appointments. So when that happens, of course, in the United States, we cannot compare apples to oranges, right? So I'm not going to compare the United States with Latin America, but I can tell you that in the United States, yes, we have plenty of resources to support patients without family members. Maybe there is some companies here that offers, companionship, and because those patients doesn't have financial issues, they are willing to pay them. Versus in Latin America, patients have a lot of support of family and friends, but the issue is financial. right? In that case, for example, in Guatemala, we are helping navigators to build a curriculum or a toolkit with resources, same in all Latin America. So every time we provide a training, we ask the new navigators to invite oncologists from different hospitals and people who are offering resources from different organizations. For example, in Guatemala, we just learned the palliative care is a new concept in Guatemala. So we found the only one organization that provides that in Guatemala. Their name is Amar Ayudando. So we invite them to present in our training to build that kind of relationship and to build better communication. So if navigators are having a patient under end of life, or a patient who doesn't have money to buy some prescriptions for pain, to connect with this organization and to help them with those resources. So those are the major barriers that I can tell you between Latin America and the United States.
Heather, have you seen, are they generally common in your experience, or do they vary by region? Or
I think that generally speaking, financial challenges are a big issue, because if you are going to a lot of appointments, you're missing work, or if you're having surgery, you're not at work. So loss of income and that impact on the family is certainly a barrier. The way that our insurance system works, and that it's very much also tied to employment, can also be a large barrier. I would say, similar to Nancy, we see a lot of issues around care, whether it's caring for a child or caring for an elderly parent or a spouse, that sometimes it's a challenge for people to find someone to care for the people in their family so that they can attend to their own needs. And transportation is certainly another big challenge. In some of our rural states, people drive a long distance and there may be tolls that you have to pay for the road. In our more urban settings, getting on and off buses or waiting in line or standing the whole time, or being in a situation where there's lots of people close that may have lots of germs for somebody who's compromised, immunocompromised, is a challenge. So I would say transportation. And I think another big hurdle that a resource navigator can help with is here in Maine, it's pride, right? That people don't want to admit that they need help or they can take care of themselves, that there's some stigma attached to needing assistance, or, I don't know, sometimes there's a little bit of shame in admitting that you don't have money for food or that you can't afford your medication. So building the relationship with the patient as a trusted person, as a safe person, that they can share that, yeah, the doctor just gave me a prescription, but I'm not going to have any money to fill it until next week or next month, or, I'm not eating like I'm supposed to be. I think those relationships that you build and then finding those resources, I think that's another barrier where resource navigation and being a trusted person really can make a big difference.
Thank you. There's someone hammering upstairs, so if you hear that, my excuses. Can you, either of you, talk about, this is the million-dollar question, a manageable patient load, how you determine, or how your facility or organization determines how many navigators to hire? Can you give some advice in this area?
I can start. For example, Dana-Farber right now, when we started the program, that was in 2005, and they decided to have 2 navigators for as a pilot project. And after that, they hired a third one. And right now we have 3 navigators, and we are looking to have at least 7 navigators. So we are looking to have 1 per clinic for the disease center. The way we do that is, first of all, we have funding is we're looking for grants to fund the program, and after 2 years, the program becomes part of Dana-Farber as like dollars of Dana-Farber. The criteria to implement navigation is to serve, for example, the most needed communities based on health insurance and, of course, barriers. And also is to provide best services for all patients, right? So that's part of the Dana-Farber criteria. Brigham and Women's, also they are growing their program, and they want to have perhaps not 1 navigator per clinic, but at least 1 navigator per 2 or 3 clinics to combine the dollars and combine the resources and the navigator's role. Going back to Latin America, I can tell you then we learned that in Argentina and Colombia, both has volunteers. Colombia has nurses, and what they are doing is they're hiring navigators in Colombia. Depends of the volume of patients, right? We learned that breast cancer and cervical cancer sometimes could be the highest numbers in all countries per se. In Dana-Farber, United States here, we can see that breast oncology patients are one of the highest numbers that we can have versus cervical cancer and also lung cancer. And so that's the criteria that we use here. And for example, in Guatemala, we can tell that right now volunteers, when we review their data, they are serving patients from breast, prostate, and stomach cancer. And remember, in Guatemala, we have volunteers, and some private sector have navigators for the whole institution. So for example, Grupo Integra, who is a public sector of oncologists in Guatemala, right now they have 2 navigators to work with all patients coming to that institute. Thanks.
And Nancy, just quickly, when you talked about the navigator per clinic, are you talking about a resource navigator or a clinical navigator? Just wanted to clarify.
Yeah, well, yes, thank you. We are talking about lay navigator or resource navigator per clinic. In Dana-Farber, we also have more than 60 nurse navigators in Dana-Farber, okay? So
big place, lots of navigators. Wow, okay, that's a lot.
It is a lot. So what they are doing right now is not converting, but I think it's just to move from nurses to nurse navigator to support patients with clinical issues, right? Because I know that you talked about this before, but just to clarify and sometimes to refresh, a clinical navigator in Dana-Farber has to be a licensed person, a nurse person, and they will deal with the patient about chemotherapy, side effects, radiation, and medication. But and they definitely go back to the oncologist, but that's their role. And also support lay navigators like our role to provide different resources, and so everybody is on the same page and everybody has the same information from the patient. So when the patient is coming back, we know who is working with the patient and we don't duplicate efforts. Thanks.
Heather, do you have anything to add to that?
The only thing I would add is that I think sometimes the resource navigator gets assigned to the patient problem that's presenting the most challenges or that is having the worst outcomes. So sometimes a hospital will look at data and find out, we have patients that are in the hospital for blood cancers, but they're getting lost or they're not getting any support when they transfer into the outpatient clinic for their regular treatments, that there's no support once they leave the hospital. So a resource navigator may be assigned to work with that population. Or it may be that once patients are coming daily for radiation for 30 treatments, that that's a population that really needs support because of the cost of coming back and forth, or because they need to find somewhere to stay for the duration of treatment, because they have childcare issues. Sometimes it might be a certain population of patients. So we know that patients who have head and neck cancers have a really hard time because of the treatment and the diagnosis. So that may be a population that needs more support. So sometimes, you know, I think you can never have enough resource navigators, and no one will never have enough resource navigators. So sometimes the decision is what group is, you know, in need of the services the most, and start there. And when there's some success, or we see that, you know, the resource navigator is helping people keep appointments, or having less side effects, or staying out of the hospital, or not having any kind of urgent situations, then maybe at that point some additional resource navigators could be added.
Great. So it sounds like it's a potential triaging of either different cancers, deciding these cancers are the ones that present more challenges, or triaging at the patient level, but it always depends back on your resources and what you have available.
Yes.
And also, even more broadly, do you have other types of navigators who are taking on other support? So it's not a magic answer, right? It's a constant conversation. Okay, I think we are going to go ahead and open it up to broader questions from the community. Jessica, I'm going to hand it over to you. Thank you.
Okay, thank you very much to our presenters and Christy for your facilitation. We do have a couple of questions, and please keep more questions and comments coming. At the same time, should you want to ask any question in person, all you just need to do is raise your hand and we'll pick on you. You can unmute yourself and then go ahead. So Meredith, you've asked, could the presenters please speak about their experience working with resource navigators and social workers in the same facility? How are the roles separate and responsibilities managed so that they complement and not conflict? I don't know who of you wants to take that on. And maybe we can also have the second question so that you can look at both. There's the question from Jungle, which is specifically to Nancy. How do you manage the appointment reminder based on your best practice? Do the resource navigators get to schedule manually from the clinical navigators and have to note down the call manually? And if the patient cannot make it to an appointment, for example, if they cannot make it to, I think I've lost that. If they cannot make it to an appointment, who will set up the rescheduling to ensure patient will get the new schedule? So over to you, both Nancy and Heather.
All right, I'm going to hop in and talk a little bit about working with social work. So I think that there can be competition and there can be confusion, and you have to really work together to establish who is doing what, but there definitely is some overlap. So we worked hard to determine what was best for the patient. And I think, like Nancy said, patients who were exhibiting or experiencing a lot of anxiety or depression, or who we know came into the medical experience with a known mental health issue or some substance disorder issues, that those patients were best served by social work. So the social worker may in fact do those referrals for transportation, for financial resources, and manage some of the psychosocial challenges that the patient is having, because it's better for the patient to have one person be taking care of them than to have multiple people, because it gets a little bit confusing as to who goes to what. I would say that the less complex patients, or patients who have worry maybe as opposed to clinical anxiety, or can be assisted by just having a helping hand or an understanding person or a companion, or knowing that they have somebody in particular that they can reach out to, is best served by the resource navigator. And then if the resource navigator determines that the patient needs more support emotionally or behaviorally, that they can ask the social worker to see them. But I think you have to sort of work as a team, understand that there is some overlap, that sometimes you're gonna work with the same patient and pass them back and forth, but you don't want to say to the patient, oh, that's a question for this person, that's a question for this person, that's a question for this person. You want to keep it as easy and streamlined for the patient as possible. So maybe I'm the one going back and forth between the social worker asking questions as opposed to sending the patient back and forth. That's my answer about social work.
Thank you, Heather. I just want to add quickly what Heather mentioned. I just want to add that, yes, the overlap between social worker and navigation is all the time there. When we are training navigators, we are making sure that we delineate the roles of each one and understand the roles of each one for them to support each other, instead of having, like Heather mentioned, a competition, right? And sometimes patients might be confused. Patients might call navigators, oh, this is my social worker, or ask the social worker, referring to a navigator. And we have to make sure that the patient understand who is who and what we are doing, who is doing what for them, so they have that clear. But most of the time, patients themselves are confusing between navigation and social worker. That's one thing. The question about the appointments in our clinic at GYN Oncology a long time ago, and we published about it. We can share that document with you in the community chat in the DCOM. We published a long time ago that in our clinic we reduces the 49% of no-show to I believe was to 29%. That was 10 years ago. Today, we reduced 29% to 8% of no-show rate in our clinic. And the reason why that happened is because since I started, I'm a journalist, my background is journalism. So when I started working as a navigator, I realized that a lot of people didn't follow up for appointments. So instead of calling them to reschedule, I was calling them to ask why they didn't show up. So we learned that people have 26 reasons why they didn't show up. Some of the major reasons in GYN oncology was menstrual period, right? The second reason was I forgot about the appointment. And the third reason was I didn't understand the appointment versus transportation, childcare, and financial issues. So we addresses those barriers, and today we have 8% of no-show. How we work in the reminder. In our clinic, medical assistants call patients to remind appointments, plus we have a text message and an email message going 3 days prior to the appointment. The medical assistants call 3 days prior also. So these patients are having 3 reminders 3 days before the appointment. When they don't show up, I check the EPIC is our system, so I can see who didn't show up, and I call them the next day to ask the reason why they didn't show up and to reschedule. If I don't reach the patient, we send a letter the next day saying that you missed the appointment on July 13 with Dr. So-and-so, and here's the phone number for you to call and reschedule. If they didn't go back to us, the nurses now are trying to figure out, perhaps in the next 2 weeks, if those patients are calling back or not. If not, they get back to me and I call them back again. That's the way we do the reminder, and that's the way we follow up the no-show. Other thing importantly to understand is when you call patients to reschedule, again, it's important for you to ask why they didn't follow up. because now you are going to be able to address those barriers that they are presenting to you. Could be financial, could be family support, could be, I didn't know that I had an appointment, or I didn't understand why I had to have this appointment again. And that is going to reduce the number of no-show, especially if you had the time to educate that patient why it's important for them to follow up. So I hope so that I answered that question for you guys.
That's great. Thanks, Nancy. I just wanted to add a couple of things. What you just said, I think, really speaks to this ongoing needs assessment and learning about your patients. You're going to, have a broad understanding, but as you do this follow-up and asking, you're going to learn more and more about the nuances of these barriers that patients are facing, and then what, again, can you specifically do to support them. So I think that's a really great piece of advice. And again, I also want to acknowledge on this call that, some of our hospitals in the United States might have many different types of staffing doing lots of different types of activities. You mentioned medical assistants. So just as a reminder to think about, again, who and what do you have to work with? And also who has access to this information? I think that's part of Joan's question, is who can actually access this medical information? Those are only questions that you can answer in your setting. But, it doesn't have to be a medical assistant. It doesn't have to be, this is one of those things that probably many people can do an appointment reminder, but who do you have to work with in your setting? And what access to information do they have? Thank you.
Okay, thank you. Do we have any other questions? And I can see that Vijaya Lakshmi had also added to some of these barriers and mentioned that in Melaka, it can be financial difficulties, lack of family support, fear of treatment, particularly with regards to chemotherapy. So, and again, as we listen to the two of you talking, it looks like these barriers are cross-cutting irrespective of where people are located in the world. Right, anyone who might want to ask a question verbally? Okay, we'll then want to move on to the next session, which points us to some of the resources in the toolkit. And again,
Jessica,
yes,
sorry,
go ahead.
just before you move on,
yes,
I'd just like to make one point. Sorry, I was having problems unmuting myself.
Go ahead.
I wanted to say in the Uganda program, we don't actually have resource navigators. We have the clinical navigators who do some of the tasks that have been outlined as being part of the resource navigators. They do the assessment, they identify, they deal with the patient's worry. And then if the patient has more needs, then they refer them to the medical social workers. What we do have supporting the medical social workers is a resource mobilizer, whose function is to go out and mobilize the resources that Heather and Nancy are both talking about, that the patient needs to have to be linked up within the community and also within the institution as well. And so the resource mobilizer is doing a lot of this linkages and getting support in kind, as well as financial support, to be able to provide the patient support needs that the patient has. And it's kind of looking at it within Kampala, the capital city, but also more broadly, where the patients are coming from. What are their support rates? What organizations are working in that district or that region that we could potentially, the medical social workers, could link the patients to. So I just wanted to share that with you.
Okay, that's a good addition. Manjit, thank you.
I don't know, Grace, since you're on the line, would you like to add anything from the Kenyatta National Hospital experience?
Good afternoon. From our part of the world, it's in the afternoon. From the Kenyatta experience, we have our resource navigator is called a lay navigator. And our lay navigator is we a qualified social worker to start off, but then when they come into the program of patient navigation, they are trained as lay navigators and the roles of a lay navigator within the patient navigation program. So they are basically they actually usually now assess the patients, identify the resource needs that the patients could be having that would be making them not be able to access services as they should, and then match them with the resources that they may have identified. So they have a role of identifying where can we get the resources that patients can tap from in the community and within the hospital, and also identifying donors, donors who can be able to support these patients financially, because as we see in the American setting, the KNH situation, the finance is the most important barrier to the patients accessing the care, and accommodation, transportation. Those are very, very key issues that affect these patients, and not to access the barrier, the services as they should. So the lay navigator is given the responsibility of identifying these patients as they come in for the first time, and then they track them along the treatment continuum until they finish identifying areas, just helping them so that they can be able to access the resources available to help them complete their treatment. And it's a real challenge because as they come in, and most of them have financial problems, so you find the lay navigator is really having to find out where can we be able to get finances to support these patients. As much as they have some people who are able to donate, and some organizations who are able to support the treatment, sometimes they just get, they are not able to find enough financial help to be able to help these patients to continue. So it becomes a problem. And sometimes the hospital, through the hospital systems, they are able to help these patients access some of the services within the hospital so that they can be able to pay for them much later when the finances are available. So this is what our lay navigators help to do. And for accommodation, the patients, some of them come from very far, and they come in and they're supposed to continue to have treatment continuation. And so the lay navigators assess these patients, and they try to find available accommodation places, and just help them to be able to be accommodated. There are some people who sometimes sponsor these accommodation places, but and some people can also donate some funds to pay for the accommodation so that the patients can be able to be accommodated and continue treatment. And the other area is the psychosocial issues. And the psychosocial issues are so many. Patients have a lot of fear, a lot of worry, a lot of anxiety, a lot of family issues. And when it is extending too much, then they are referred to the social worker to help. And also when it comes to something like home placement, community placement, sometimes they refer these patients to the social worker so that the social worker can be able to continue with them. And but the lay navigator is stationed within the navigation where the navigation is taking place is implemented so that they can be able to work with this patient, identify these issues, and address them as they come in. So,
thank you.
Yes, thank you.
Thank you, Grace. I would like to go back to Nancy very quickly, and then we can move on.
Yes, thank you. Just one thing, to reduce the no-shows, what we learn in our clinic is that right now I am sitting and meeting with all new patients, regardless of financial education background. Every time we have a patient coming to our clinic, we are having the same information, like why it's important to follow up appointments, how to reschedule appointments, and don't get confused between regular GYN appointments versus GYN oncology appointments, because most of the time women get confused having a regular pap smear in a regular GYN clinic versus having a colposcopy, biopsy, or loop procedures in a gynecology oncology clinic. So I explained to them, now I learned that sometimes it's easy to explain to them that when they go to the dentist for a cleaning, that's a cleaning visit. But when they go to the specialist for a root canal, that's a different provider or a different doctor who's going to perform the root canal. So I just like to compare that to our clinic for them not to get confused. And that helps us to reduce the no-show rate, because now they have an education at the beginning and why it's important for them to follow up. And later we are having more patients calling us back to reschedule their appointment. And it's interesting because now when they call, they already tell the reason without us asking the reason. So they call and says, oh, I'm gonna reschedule because I have a job problem or a childcare issue. So they are answering now those questions. So when you educate your patients, you can anticipate that now they're gonna be more, in charge of their care, and also in charge of following appointments. Thank you.
Okay, thank you. Festus, I see your hand is up, and in the interest of time, can I please request you to put your question on chat or in the community, and then we get to have an opportunity to finalize today's program in time. So thank you to all the presenters. And again, from the information that you've received today, you might find that there are more questions coming up. We are not letting go of you, Nancy and Heather. Okay, yes, Festus?
Sorry, Jessica, I just muted this. Let's
okay.
moving forward, and then if you can see the question in the chat, we'll try to get it answered before the end.
Yeah.
Can we go to the next slide?
Yes, so carry on, Christy.
Thank you.
Okay, thank you. Good afternoon, everybody. Based on the question that was asked earlier about who to reschedule appointment if patient failed to adhere to previous appointment. Here how we design it is that every clinic day has a repetition of it on weekly basis. Because of the nature of the reasons that might be the cause of that patient to miss appointment, you cannot really say when they've overcome the challenge that caused them failing from the first appointment. So we'll make it to be a kind of a fixed appointment that will run on weekly basis. For example, if you are seeing your doctor on Tuesdays and you fail to come on a particular Tuesday, we accommodate you the next coming Tuesday, except there is an emergency that will force you not to be able to wait till the next Tuesday. Then you can come up as an emergency case, then we'll admit you from there. Thank you.
Okay, thank you for that addition, and well noted. Thank you, Christy.
Okay, thanks, everyone. So I really appreciate our speakers today sharing their experiences. I'd like to quickly refer back to the toolkit and where we have resources that can support you with your resource navigation generally, specifics around your staffing needs. So can we go to the next slide, please? We talked about this a lot today. We talked about it 2 weeks ago. Role delineation. I think what the take home I'm hearing is that this is not a one-time, we figured out the roles, everybody's clear, nothing ever gets confusing. This is an ongoing effort. So I think the key here is it's important. And I wanted to share a nice resource that's in the toolkit that the American Cancer Society historically used as the in-scope and out-of-scope summary. This was a starting point for conversations with health facilities to say, hey, we want you to understand the services that our navigators are bringing. This is what we can do. This is what we can't do. It doesn't solve everything, but it does start to get everyone on the same page about this delineation. Also, qualifications. Next slide, please. Credentials. As you can see here, we've talked a lot about really with resource navigation, you don't need specific credentials. Many in the United States, high school diploma, if you have a bachelor's degree, great, but not required. I think you heard Heather talk a lot about really the qualities and those soft skills that a resource navigator needs. So be thinking about that in your setting. And just to say that, again, in sections 4 and 6 of the toolkit, we have a lot of resources to help you think about, again, those skills and qualities that you have. Next slide, please. For recruitment, again, you're going to have to think about your resource base. You're going to have to think about if you're starting your program, do you have existing staff that once you understand what you want to do with resource navigation, that you think would slot into that well? Maybe you recruit and transfer them. Maybe you decide to bring on new people and you need to figure out how to recruit new folks to fulfill these roles and find those right people. If you're a health facility, we've talked a lot about this partnership with community organizations. So be thinking about who in your wider environment might be able to bring this service to your health facility and start having those partnership discussions. And of course, if you're a cancer organization, I already know that you are knocking on the doors of health facilities to say, hey, we're here and we want to offer these services. And that's really great. Navigation numbers, we mentioned this resource last time. In section 5B, we have some ways to start thinking about calculations for your navigation needs based on your patient numbers, based on which cancers you want to serve or populations that you want to serve. This is a starting point. So please take a look at that, but also know that as you get into implementation, you're going to start having a greater understanding of how much time your navigators are spending with your patients. And you'll get better and better at figuring out really what's that ideal number of navigators that you need for your team. But check that out in section 5B. All right, and then just on this last slide, we have our summary of helpful resources. As you can see here, we have a lot of different resources across sections 1, 4, 5, and 6 that will help you figure out broadly your types of navigators and staffing needs, but also very specifically resource navigation. So want to make sure that you have that handy to check out. And again, as always, you are welcome to reach out to us if you have clarifying questions. So I'm going to hand it back over to you, Jessica. Thank you very much.
Yes, and as we come to wrap up, we have noted that in many of the previous virtual events, our team has prepared and given a lot of information. And as part of getting feedback from you, as well as facilitating learning, because this is a community of practice and a community of learning, we want to be more engaging and to also hear from you, what is it that you're doing? How are you faring on in terms of your engagement with the toolkit, or even the way in which you're designing your programs? And so we've created an opportunity where in the different virtual events, we will provide some 5 to 10 minutes for any FPO that wants to give us a brief overview of what you're doing and how you're progressing and how you're utilizing the knowledge that you're getting from these meetings to build onto your program, so that we can learn from you We can also get to hear if this is working for you, as well as even get to hear any challenges that you have that could translate into further communication in the community. So we are calling on any volunteers, any organization. You do not need to be perfect. We are not looking for people who already have very well designed programs. We just want you to come and speak to us, as we've had different people talk about how they're working in their different institutions. And so coming the next virtual event, which is July 28th, we look forward to having our first FPO come on board and tell us a bit about what it is that you're doing and what are the initiatives or steps that you've taken or put in place since we started engaging and interacting with you. Kindly reach out to us at least by the 20th so that we can sit with you and maybe even plan. If you do not need any assistance, that's still okay, but we'll be able to share with you via email what are some of the things that we would like you to pay your attention on in those 5 or 10 minutes. If you're ready to volunteer, you can actually do it now. You don't need to wait for 20th, and put it on the chat and we'll reach out to you immediately. So as always, your technical assistance hours are there for you to utilize. And remember, we help you to clarify content of toolkit activities. We support you with brainstorming, troubleshooting. We will help you save from today's session on troubleshooting role delineation challenges between resource navigators and other staff, provide feedback on any drafts that you might have produced, or even help you strategize with your recruitment, with your planning and staffing needs as needed. What we will not do, as we always insist on, is to develop the documents for you. However, we can review those documents or decide how you, Obina, please. Or decide how you will meet your resource staffing, resource navigation staffing needs for you. So please feel free to reach out to us, and you do know the email by which you can reach out to us, which is beacon@stepsahead.co.ke. Exciting webinars coming up. Remember to mark this on your calendars, and we always send you reminders and invites. On the 28th of this month, we will continue with our series. And on 28th, we will then be talking about physical navigation. Notice we have talked about clinical navigation. Today we spoke about resource navigation. And so we continue to build this on with our discussion on physical navigation staffing needs. And on 18th of August, we will talk about, we will do an introduction to section 7, learn and adapt your program. You can always watch the event recordings on the icon that you will find in the home page. So should you have missed something, or someone in your team that might want to go back to areas or recordings that have been done, you're welcome to do that. As we come to the end of today's session, again, please give us your feedback. Take that 2 minutes to tell us if today's session did meet your expectations. Shahid, if you haven't, please post the survey and tell us more about how you would want us to be of more value to you in future virtual events. Your feedback is anonymous. What we share is collated information from the various respondents. And with that, we'd like to bring an end to our meeting today, thanking all the resource persons that have come in to share their knowledge and experience. As you share of yourself to us, we have gained, we are learning, and I'm sure that people will be picking 1 or 2 things that they can utilize and make use of back in their organization and in their programs. And to all of you participants that still create time to be here, the fact that you show up for these meetings encourages us to want to continue to generate more virtual events for all of us. So thank you for coming on board, and thank you also for staying through to the end. Remember to fill in the survey. Goodbye and best wishes in your work.
Thank you, everybody. Have a wonderful day.
Thank you.
Thank you, Nancy and Heather.
Thank you.